I would say welcome to Pernette, Bourdillon, Esteve, if I pronounce Esteve right, from WHO. So you give a presentation, and after that we have another presentation, and then it's time for discussion.
Thank you, Susan. Can you hear me? Yes. Thank you, Susan. So my name is Pernette Bourdillon Esteve, and I work for the World Health Organization in Geneva. And I work for the global program on surveillance and monitoring of what is called SSFFC medical products. So that stands for Substandard, Spurious, Falsely Labeled, Falsified, and Counterfeit medical products. It's a long acronym because it's a political agreement, but I hope that maybe in the future we'll be able to simplify that. The real question is, what are, I'm a bit confused because it doesn't swipe the same here. What are falsified medical products? They're not related to intellectual property reasons. It's got nothing to do with IP rights. I'm sorry, it's just I'm a bit perturbed by the format. Medicines that have been falsified include both very expensive medicines. So Paul was talking about Malarone, which is very expensive, but they also include very cheap medicines. It's not a question of price. Either people will falsify medicines in bulk and sell them at a very cheap price. We have a lot of paracetamol, a lot of aspirins that have been falsified, a lot of antibiotics, or they will manufacture in less large quantities, in smaller quantities, and sell at a higher price. Falsified medicines tend to be... How do I switch? How does this work? It's not at all the same. Okay. They're difficult to detect. Paul showed you some good photographs. It's impossible to detect. Even a trained pharmacist will not be able to make the difference between a genuine product and a falsified product. And they're manufactured in all countries and available in all countries. You'll hear a lot of people say that most falsified medicines come from Asia. We have case studies of falsified medicines being manufactured and distributed in Europe or in the Americas. And the harm caused is quite varied. It can be anything from a toxic contamination. The medical product, well, what is supposed to be a medical product, not only does not contain the active ingredient, but contains something else that is toxic, a different ingredient that will cause a toxic reaction. Quote unquote, in the best case scenario, when it just doesn't contain any of the active ingredient, it will cause therapeutic inefficiency. So you can imagine the harm caused when those are life-saving medicines, when it's an anesthetic that's got no API or only have 50% of the API. We have reports of people waking up halfway through surgery, or when you have diabetic medicines that don't work. And there's also the economic and social damage, which I'll get back to, but you can imagine the cost of public expenditures of public healthcare facilities buying products that not only do not work, but then they have to treat the people who have been contaminated by medicines that were failed and that were contaminated. So what's the WHO role and responsibility? First, we have recognized that there is a significant threat to public health, and most importantly, that there is no body of validated data on the scope, scale, and harm caused. It's all very well to recognize that this is a problem, but to be able to tackle the problem, you have to know what you're talking about. So to do this, WHO is developing a global database of all reports of substandard and falsified medicines. All countries worldwide are slowly being trained to report to this database, and WHO provides immediate technical and operational response, helping countries deal with these situations. And countries who have to deal with this situation include all sorts of countries, whether we're talking about European countries or countries in Africa. And when countries are not used to dealing with these type of problems, they generally need help, whether it's crisis communication to backtracking all the patients. And based on all this data, we try and develop evidence-based policies and which will help guide the resource allocation, because we all live in a world where funding is very limited, so you have to know where to best allocate your resources. And just so you know, the photo that's here, that's a photo of all the medicines that are in my office. So, and they're all falsified. To give you an example of why we need a global system, and it's not something that you can deal with just in your corner. In 2012, in December, in Pakistan, they had a problem with some cough syrup. So I'm sorry you were coughing before, but I hope you... And so you have people in Pakistan, they abuse cough syrup for drug reasons because it contains a derivative, a hallucinogenic product. So they would swallow the entire bottle of cough syrup, which is obviously not recommended. But a lot of these people have been doing this for 20 years or plus, and suddenly you have 50 dead. So there's something wrong. Even if they're not using the cough syrup as they should be, there's something wrong. Pakistan asked WHO to assist them in this, so we went over there for 3 weeks. We helped them with the investigation, and we published an international alert because we realized that there were 2 locally manufactured brands of products that were contaminated. The product that is supposed to be in the cough syrup is dextromethorphan, and those cough syrups contained levomethorphan. So basically it's the same molecule, but it's slightly different, and levomethorphan has a much more potent action, and that is what was killing the people. And they realized that the active pharmaceutical ingredient had been imported from India, and then it was manufactured in Pakistan, and the 2 local manufacturers had just recently changed the source of the manufacturing. And in September 2013, so 9 months later, in Paraguay, they had 46 patients hospitalized. All the patients were children, and they had 3 children in intensive care. And they contacted WHO, and we realized that the active pharmaceutical ingredient, not the finished product, because you remember that for the case here in Pakistan, it's local manufacturers, and in Paraguay, it was also local manufacturers. So just the active ingredient was exactly the same, and that the patients were presenting the same symptoms. So we connected, and we realized that the supplier of the active pharmaceutical ingredient was the same from here, from India. So we were able to provide, within the 10 hours of the report, the antidote, which was naloxone, and that means that all the children survived. So you had 46 children who had overdosed on levomethorphan, and we were able to tell them very quickly how to save them. In this particular instance, we have not been able to prove that there was an intent to cause harm by the manufacturer of the active pharmaceutical ingredient. I'm not a specialist in this field, but I understand that the manufacturer of dextromethorphan, if something goes wrong along in the manufacturing process, if the temperature is not right, if the proportions of the acid is not right, then you can have a certain amount of levomethorphan that is created. So we have not been able to prove that there was a cause for intent, but this demonstrates that you need a global system, and you need countries that talk to each other. Paraguay and Pakistan would have never talked to each other. They have no particular commercial interests. There's no reason for them to have connected. And this product had been also sent to other countries, to Syria, and you can imagine that tracking the finished product in Syria was impossible, considering the situation there. To Egypt, some of it had gone to the UK, so you see it affects Europe, Colombia, and Peru. And in Colombia and Peru, we were able to warn those countries beforehand, and none of the finished product went out of the factory. So this is why you need a globalized system. And it's 8 countries over 4 continents. So the WHO Global Surveillance System, since July 2013, which is since we've been operational, we've trained 114 WHO member states and 18 procurement agencies. All in all, they've reported 1,200 products in 90 countries. And WHO has provided technical assistance in over 100 cases. So that means emergency lab analysis, going over to the country and helping do the investigation, and so on and so forth. And this has resulted in the publication of 17 global alerts. So you see that we have reports of over 1,200 products, but we only published 17 global alerts. This is because we want people to really pay attention to the alerts. So we're not going to be publishing alerts every day, and it's only in the most important cases that we'll publish the alerts. Another word of caution, 1,200 products, it's just each product. It doesn't mean the number of doses. In a single one of those products, it has caused 300 deaths and 1,000 people hospitalized. And another one of those products corresponded to billions of doses, billions of tablets. And we were just talking earlier on, you need 35 years to count 1 billion seconds. So it gives you an idea of the potential volumes, but we just count in terms of products. WHO have developed an online portal for the trained focal points where there is a search tool. They can actually search the database, the WHO database, to see that a product they have in their hands might have already been reported to us, so that can help them confirm or infirm their suspicions. It's available in 3 languages, in French, English, and Spanish. And healthcare professionals in the field will also have access to a smartphone application to which they will be able to report to their national regulatory authority. So it's all about capacity building in the field. And just going back a little bit, you can see the map here in the background. It shows all the countries that have been trained. So I'm going to give you an example of falsified yellow fever vaccine. This map here, also in the background, I hope you can see, shows all the yellow fever belt regions of the world. But this year, in February, we had a report that falsified vaccines for the yellow fever were discovered in Bangladesh. As you can see, Bangladesh is not part of the yellow fever countries, but Bangladesh was buying yellow fever vaccines for the army, for those soldiers who would be deployed in yellow fever countries. And if people among the audience have traveled to yellow fever countries, you know that you have to buy and get yellow fever vaccine. What happened was that it was a local wholesaler who was supplied by a fake employee, because they tried to get the vaccine from the manufacturer, and a fake employee sold them the fake vaccine from the genuine manufacturer. So WHO published an alert. It was very difficult to obtain the samples for bureaucratic and administrative issues because the vaccine had been supplied in the public sector, so they wanted to do the investigation. But we finally had the vaccines analyzed, and they contained high level of bacteria. So people who were inoculated with these vaccines had a high risk of sepsis. And at the same time as this was ongoing, and it's still not finished, there is an ongoing outbreak of yellow fever in Angola with almost a shortage of yellow fever vaccines. So you can see that it's really a global issue. This happened in Bangladesh. The supplier was the genuine manufacturer is based in Africa, north, and there's an ongoing outbreak of yellow fever in Angola. Another case of falsified vaccines last year. This is falsified meningitis vaccines. In Africa, they have conducted immunization campaigns where people are mostly immunized against a certain type of meningitis, which is type A, but they were not immunized against type C. So there was this massive outbreak of meningitis type C in Niger and neighboring countries last year around in 2015. And there was a stock shortage of the serotype C vaccines because it was very expensive and it was generally only dispersed to people traveling to those regions. And furthermore, there had been a problem in the production because the 2 manufacturers had difficulties in producing enough stock. And then we discovered that there was falsified vaccines available for type C. And there was just as Paul had showed you before, there was a malaria outbreak that corresponded to a low quality supply of malaria medicine. We realized that there was an exponential increase in the meningitis outbreak at the same time as falsified vaccines were available. So we published an alert and we also provided some support. So in all the case studies that I'll be showing you and this one, you'll have recurring vulnerabilities that appear and which will be present in more or less quantities for a richer or a poorer country. But it's always about unregulated supply chains, regulatory agencies which are under-resourced or who do not know how to deal with the problem, poor procurement practice, and the distribution chain is not well controlled. It's also about poor quality to affordable and effective medicines. We have seen that expensive, like very cheap medicines are affected by this. So stock shortages or price differentials. If you think it's cheaper to buy somewhere else, they might buy somewhere else, but it doesn't necessarily mean that it's from a good source. And of course, there's the lack of the effective regulatory and criminal justice system. So it's, of course, very important to prevent upstream. It's important to know how to deal with the problem, but it's also important to deal with it afterwards. If the criminals who have distributed falsified medicines are not appropriately punished, they will continue to do so. And that's the problem in many countries. Every single therapeutic category is affected. So I've highlighted here just the 2 top categories. So antiparasitic products include mainly antimalarials, and anti-infectives for systemic use, those are antibiotics. And within the antibiotics, the most frequently reported antibiotic is amoxicillin. And I think that everyone in this room probably has used amoxicillin at one point in their lives. There's a strong likelihood. The fourth most reported therapeutic category is the genitourinary system. And I'm not talking just about the Viagras and the Cialises and lifestyle drugs. This is more about reproductive health issues. And you can see here you've got emergency contraceptives. So this is what they call a morning after pill. This particular product was seized in Uganda, and it had a genuine batch number, and it contained 0 active pharmaceutical ingredient. It's a WHO pre-qualified product. Now, WHO pre-qualified product means that a lot of people place trust in these products because they are manufactured with a high standard of quality, and it was imitating a product that has a high standard of quality. So you can imagine a young woman who knows that she has to take the morning after pill, and she takes this falsified product, which has got 0 active ingredient, and the pregnancy continues. I didn't put it up, but I could have put the map of abortion access to a termination of pregnancies in the world. There are a lot of countries in the world where it's not easy. So a young woman who has her pregnancy, who is not terminated early, gets pregnant, what will she do afterwards? She might have terminated the pregnancy in very unhealthy conditions, and her life might be at risk. So you can imagine all the impacts. So when we talk about the harm caused, it's not just about a medicine that doesn't contain the active pharmaceutical ingredient. It's what goes on afterwards and around. This is another case study. I'm sorry, most of the case studies I'm showing you are from the sub-Saharan regions, but that's where we get the most reports from, because that's where we have trained the most countries from. Where we have the most reports from doesn't necessarily mean that's where they have the most problems from. It's where they have the most reports. If you don't look, you don't find. So in July 2015, in this area in Congo, which is close to the border with Uganda and South Sudan, they started having up to 1,000 hospitalization, up to 40 hospitalizations a week, which you can imagine you don't get hospitalized just for a headache in these kind of areas because access to healthcare facilities is quite difficult. And this is the village where most of the symptoms were occurring. And they were having acute dystonic reactions affecting the face, neck, and upper limbs. So basically it means that all the upper part of their body was paralyzed, and it was very painful spasms, muscle spasms, sorry. And children were most affected. So Médecins Sans Frontières was the NGO who was over there. Initially they thought it might have been a meningitis outbreak, and they investigated the root cause system, and they informed WHO. After investigation, it was found out that patients were taking diazepam. So diazepam is the active pharmaceutical ingredient in Valium, you know, what people take to sleep. And people take it to treat malaria in those regions because there is, they don't take medicines the right way, but also because it's to treat sometimes the spasms that are related to that. And the adverse reactions that they were showing did not correspond to the adverse reactions that people might have been having with diazepam. It corresponded to adverse reactions people might be having with haloperidol. And the clinical samples revealed traces of haloperidol, which was confirmed by lab analysis and alert. And the samples of the diazepam actually, what was called diazepam, they tested positive for 10 to 20 milligrams of haloperidol. So you can imagine children taking up to 20 milligrams of haloperidol. That's far too violent for them. These are the two kinds of bottles in which the fake diazepam, but in fact it was haloperidol, were found. And you can see here, yeah, you probably can't read, but it says distributed by the government of Uganda, not for sale. Both products were being sold. So what happened, in fact, is that there was a high demand for diazepam in the region because people were using diazepam for all sorts of reasons, for malaria, to sleep, for everything. And there was a stock of haloperidol that was nearing its expiry date. The shelf life was disappearing. So they emptied the haloperidol, they deblistered it, and they filled up the diazepam bottles with the haloperidol. And they sell the haloperidol as diazepam because they can sell the diazepam. Everyone wants diazepam, but haloperidol is an antipsychotic. No one's going to want to use it. It's not used. So in the bottles which are labeled Diazepam, in fact, it contains haloperidol. You see? So you have all sorts, every incident is different. There's always a different reason, but basically it's always about the money. They're always trying to make money with it. So what damage is caused? Well, they harm patient and consumer health, as you can see here. They undermine efforts to strengthen health systems, because if you have a weak health system which is always running around trying to cure patients that have taken the wrong medicine, then it's difficult to progress. They weaken medical product markets and supply chains. They reduce access to safe, quality, and efficient treatments, because it's one thing having access to treatments, it's another having access to a safe and efficacious treatment. They contribute to antimicrobial resistance and impair treatment strategies, because if you continue to have the circulation of substandard or falsified medicines which contain a reduced amount of active pharmaceutical ingredient or zero active pharmaceutical ingredient, well, that might contribute to the development of resistance, and in the long term, you're going to have to change treatment strategies. Just like quinine sulfate, you can't use it to treat malaria in certain regions of the world. It might be the case for antibiotics in other parts of the world. They undermine national treatment programs. For example, when you have a story of a falsified vaccine, people tend to be distrustful sometimes of vaccines. So you can imagine the impact it will have if people say, well, oh, this is a falsified vaccine, so I'm not getting vaccinated. And you will have then 2-3 years later on, you might have an outbreak of the disease which you try to immunize people against. And of course, it's always the most vulnerable populations which are most at risk, because they are the ones who try to buy their medicines in maybe a non-regulated supply source, and it's out-of-pocket expenses. Just one point, it's really important to insist on the fact that both very expensive and very cheap medicines have been falsified. And when we have a look at the price of medicines which are available, we see that it doesn't make much of a difference, that sometimes you buy it in the private sector, or you buy it in a regulated or an unregulated environment. The price difference is very small. This is my last slide. It's just to show you that the European region is the second largest reporter. So it affects all regions of the world, all therapeutic categories. Everyone's affected by this. Maybe you can have a, I mean, this is a bit long. I'll just pass it. So that's it.
Thank you very much.